Welcome to another video. Today we will be discussing the medical management of type 2 diabetes, specifically looking at the varying pharmaceutical drugs that can be used to combat this endocrinological disorder. Specifically, we will be going over the varying guidelines, how they compare and contrast to one another. We will be going into some detail about the available classes of medications, their mechanism of action, their pros, the cons, and reasons when you would and would not prescribe them. And again, we'll be going through some case studies to apply this in real life scenarios. So as you can see, I'm quite an enthusiast when it comes to diabetes and endocrinology, and I do hope to share that enthusiasm with yourselves. So I've titled this page, it's all about the A1C, because in essence, when we are managing diabetes mellitus, that is all we are focused on. We're focused on getting the A1C, the glycosylated or glycated hemoglobin, below 7.0%. If they're very young or if they're not at risk for hypo episodes, we may consider less than 6.5%. So when we think about type 1 diabetes, we know everyone requires insulin for survival, but in type 2 diabetes, we're starting to shift away from giving insulin to everybody. The reason being, of course, insulin increases the risk for hypoglycemia and it increases weight gain. As we know, people with type 2 diabetes are typically already obese and it can really impair with compliance. So there's certain times when insulin would be necessary in type 2 diabetes. And this is something we see from the AACE, the American Association for Clinical Endocrinology. If we take a look, they recommend with an A1C above 9.0%. That's really because most medications, which we'll go into in detail later in this video, don't seem to decrease the A1C by more than 1 to 2%, whereas insulin can cause dramatic drops in an A1C. We actually have to notify patients that they may see such a dramatic drop. They'll get transient visual disturbances. They might also get something called insulin neuritis, whereby there is a temporary paresthesia, strange discomfort, potential burning pains in nervous distributions. So the AACE recommend starting long-acting basal insulin. They do break it down based on the A1C less than 8 or more than 8, but realistically, when the HbA1c is more than 9%, they start basal insulin. Most physicians you'll see would recommend, regardless, starting at 0.1 to 0.2 units per kilogram. You'll also see a lot of physicians outright prescribing just 10 units at nighttime. This, of course, we don't stick with 10 units. We recommend every 2 to 3 days. If they've had 3 days in a row where their fasting blood sugars in the morning are higher than expected, we would recommend they increase it by 1 or 2 units. The opposite, of course, if they have hypoglycemia, we don't recommend having 3 days of hypoglycemia in a row. We would recommend an immediate reduction of 1 to 2 units. We can see they provide an adjustable regimen on the AAC guidelines, but it's really dependent on the physician and the patient's compliance. Another thing to consider is they may very well start basal long-acting insulin at bedtime, and they may have good sugars in the morning, but their A1C is still elevated. And then we would consider intensifying this. We'd give prandial or bolus insulin. This is given before the meals. Most physicians would start by giving just one prandial dosage. So we'd find the largest meal of the day. It's quite difficult for people to say which meal is their largest. So we'd say which one has the most carbohydrates or is likely to produce the greatest glucose spike afterwards. And we would start with giving a bolus insulin right before that meal. And typically, the guidelines say 10% of the basal dose, or again, you'll see patients being given a flat out 5 units and slowly up titrated. We would tell patients to monitor their sugars 2 hours after that meal and see if they've come down to an acceptable range. Of course, if this still doesn't get the A1C under control, we may consider giving a bolus before every meal. Now, the AAC guidelines are starting to suggest perhaps considering a GLP-1 receptor agonist before insulin. As I've said, most medications don't decrease the A1C by more than 1 or 2%. GLP-1 receptor agonists are starting to show perhaps they can decrease the A1C by more than 1 to 2%, so it's something to keep in mind. If we compare this now to the ADA, American Diabetes Association guidelines, quite similar. They recommend, again, consider a GLP-1 receptor agonist prior to insulin, but they do note here that sometimes it's contraindicated. Sometimes patients are already beyond a GLP-1 receptor agonist, and there's also situations where they should go straight to insulin. And the ADA recommends when the A1C is more than 10.0% or blood sugars are more than 300 milligrams per deciliter. Also, if they have severe osmotic symptoms, symptomatic hyperglycemia, or if you can't tell the difference between type 1 or type 2. You would rather put them on insulin and then figure out, okay, it's type 2, we can potentially decrease their dosage of insulin or switch to another medication. But it's essentially the same recommendations. Start a long-acting insulin at bedtime. Again, you see the 10 units are 0.1 to 0.2 units per kilogram, and it's titrated every 2 to 3 days as appropriate. Now, if we take a look into the non-insulin class of medications, just want to show this timeline. We see that in the 1920s there was insulin. In the 50s is really when we get the first breakthrough for non-insulin medications with sulfonylurea and metformin, and we can see there's quite a gap, about 40 years before there's the next breakthrough, and to this day we're still having new discoveries. And it's quite interesting to see that although metformin was identified in 1959, it was used quite often in Europe. It actually wasn't brought to the market in North America until the 1990s. So if we take a quick look, these are the ADA, American Diabetes Association guidelines, and it's quite a messy recommendation, it's fair to say, when looking at this in the untrained eye. Essentially, as with every guideline, we start all patients on metformin regardless, unless there's a contraindication. We also recommend lifestyle adjustments. Now, this means increasing the physical activity, a mixture of aerobic and resistance activities, as well as weight management, mainly through diet. Things we'll recommend are the DASH diet or a Mediterranean type diet. Now, again, this is quite a difficult chart to follow, but I always recommend, and it's of course my opinion, ignoring this side. The reason being, as you can see for an example, cost is an issue. Well, they recommend considering a sulfonylurea or a thiazolidinedione. We'll talk about more about these classes in a bit. But if you're prescribing a medication just because of costs, you're not necessarily giving the most effective medication. And we know diabetes type 2 specifically is a progressive disease where the pancreatic beta cells become more and more exhausted. We know by about 3 years, 50% of people will require more than one medication. So essentially, you're giving them a medication which may be cheaper, knowing eventually they'll require a stronger medication over here. So it would make more sense, really, to go straight to the better medications. The same thing about minimizing weight gain, promoting weight loss. This is a category whereby if they're very, very obese, you would consider certain medications which are good at promoting weight loss. They also have a category about needing to minimize hypoglycemia. But essence, the guidelines emphasize the most important thing is considering if they have atherosclerotic coronary vascular disease, if they have chronic kidney disease, or if they have heart failure, or if they're at risk for atherosclerotic coronary vascular disease. And guidelines nicely break it down into these two categories. So if someone has atherosclerotic coronary vascular disease, it's important to note a very common way of being diagnosed with type 2 diabetes is actually on the cardiac care unit post-myocardial infarction. But they also list the risk factors if you're more than age 55 and have a artery stenosis of more than 50% or left ventricular hypertrophy. In this case, we would recommend metformin plus a GLP-1 receptor agonist, not just any receptor agonist, but one with proven cardiovascular benefit, which we will talk about in a moment. If a GLP-1 can't be given for whatever reason, then we'd give an SGLT2 inhibitor. Now, when considering heart failure or chronic kidney disease, it's essentially the opposite. We would give SGLT2 inhibitor, and if that is contraindicated for whatever reason, then we'd consider a GLP-1 receptor agonist. Now, it's important to note that an SGLT2 inhibitor can be used in heart failure even without diabetes. They're that effective. And by chronic kidney disease, they recommend a reduction. What they describe of this is a reduction in EGFR or albuminuria. So whenever you see they have albuminuria, we want to give the SGLT2 inhibitors because they're nephroprotective. What's important to note is although GLP-1 receptor agonists are not licensed for nephroprotection, various recent trials such as the LEADER trial have shown they actually do slow the decline in kidney function and are nephroprotective. So they can be prescribed for this, but it's off license. If we move now into the AACE guidelines for treating type 2 diabetes, it's quite similar. We look at the atherosclerotic coronary vascular disease risk and CKD. They do break it down a bit more into the A1C category, and what I like about this is they say if it's less than 7.5%, consider monotherapy. If it's 7.5 to 9%, consider dual or triple therapy. And why is this important? As I've said, most medications won't decrease the A1C by more than 1 to 2%. So if it's this high, realistically, metformin on its own isn't going to do much, and we need to intensify it early on. Another important finding is what was found in the Verify trial, and these were patients given metformin alongside vildagliptin, a type of DPP4 inhibitor we will talk about in a moment, and they found that there was a slower decline of impaired glycemic control when both medications were used off the bat compared to metformin alone, or compared to metformin alone and vildagliptin subsequently added at a later time. Therefore, what this suggests to us is that there's better glycemic control when we tackle it with the drugs at first, rather than waiting until there's more decline in beta cell function and then adding on more medications. It's actually very uncommon you will see the name biguanide, mainly because there's only one medication in this class on the market, and that is metformin, which is probably the best studied medication, the most well known, the most commonly prescribed one, so therefore it's more common to see metformin. There were two other medications in this class, fenformin and buformin, but in the 1970s they were withdrawn, so taken off the market because of the heightened risk for lactic acidosis, which can be fatal. So it's important to note, as I've said, metformin was discovered in the 1950s, but it was used straight away in Europe, but it really wasn't until the 1990s this came into effect in America, and we started seeing the benefits as a result. So metformin is the first line treatment for type 2 diabetes in every guideline, whether that's in North America, South America, Europe, Asia, Australia. And it's important to know every patient should have metformin unless there's a reason why they shouldn't, so unless there's a contraindication because of the multiple benefits we've seen. So you might also see metformin called glucophage, that's known as the trade name. Metformin is the generic name. And it's important to note this comes in two forms. There's an immediate release form where we take it multiple times a day, or there's an extended release form where we take it once a day. The immediate release form is what we typically start first because it's cheaper. So, as I've said, this is the most common medication prescribed for type 2 diabetes, and it's quite ironic actually that despite being the most commonly prescribed medication, we don't fully understand how it works. We know there's multiple mechanisms we found, and they all seem to give benefits and risks, but we don't know which one is the most important, contributes the most to these benefits we see. So things metformin does, it decreases the hepatic gluconeogenesis, that is the production of glucose within our liver, and it seems to do this through interfering with the respiratory mitochondrial chain complex. It also, as we see here, inhibits an enzyme known as glycerophosphate dehydrogenase. Additionally, metformin seems to interact with the 5' AMPK pathway, and what this pathway is involved in is energy regulation and satiety. We know that metformin will lead to a decrease in free fatty acid substrates, and these are what are also used for gluconeogenesis. So as a result, again, there's less glucose being produced from the liver. We know that metformin appears to increase the sensitivity to insulin within the periphery, specifically the muscle and the liver, so increasing the insulin within their system. As we know in type 2 diabetes mellitus, the body is resistant to insulin, so this improves its sensitivity. All of these effects seem to lead to less food being taken in, and the weight will either stay neutral or there will be a mild decrease. Recent evidence has also come out suggesting that metformin increases the endogenous levels of glucagon-like peptide 1 within the gut. We'll get more into this later when we talk about that class of medications, but GLP-1 essentially is a molecule within the gut, and it's released from the small intestine. It increases insulin release, it decreases glucagon release, and it seems to promote early satiety, so we eat less. So what to know about metformin? This is probably the most important drug to know about the dosing because it comes up on nearly every exam, and it's something really all healthcare professionals are expected to know. When there's an EGFR of above 45 milliliters per minute, we don't worry. The full dose can be prescribed, and that is a maximum of 2 grams per day. As I said, it's the immediate release we typically start with, so we typically give 500 milligrams at dinner. This is followed by 500 milligrams at breakfast, and there's a slow titration. Roughly every 2 weeks, a new tablet is added until we get to that maximum dosage. When the EGFR falls below 30 to 45, it's a bit more tricky. typically we say the maximum dose is 1 gram per day, so that's reduced by 50%. Some guidelines suggest we don't initiate metformin, but we can continue it. Others suggest we can initiate metformin, but at a reduced dosage. But when the eGFR is below 30, most guidelines agree metformin, actually all guidelines agree metformin is contraindicated. So this is both suggests do not initiate it and discontinue if it has already been initiated. Now it's really important to know that one of the commonest side effects is GI intolerance, so nausea, vomiting, and chronic diarrhea. Some patients, the diarrhea is transient and will go away, but a lot of patients it actually won't. And if this happens, we want patients to let us know so we can switch them to the extended release metformin once a day. The reason is we don't want patients to stop taking metformin because of the multiple benefits it has. So when we give the extended release metformin, it typically stops that diarrhea. So extended release metformin, as in the name, is an extended release, therefore it's given once a day. Again, it has the maximum of 2 grams a day. Now it's really important to note when giving the extended release metformin that patients may occasionally actually see the capsule in their stool. That's because the extended release form over 24 hours releases the medication from the capsule, and therefore, depending on the gut transitory time, you may see part of the capsule in the stool. That is completely normal, and patients should be warned of that beforehand. So as we've said, it can upset the metformin can upset the gastrointestinal tract. It also can lead to lactic acidosis, albeit rare. It can be fatal, and it's very important to know about this. Examinations love to ask what type of lactic acidosis it causes. So metformin causes type B. Type A is what you see with hypoperfusion states, such as sepsis or severe volume depletion. Another thing patients may complain about is a metallic taste when they take metformin, but again, hopefully we can convince them to continue the medication. Long term, it appears as if metformin depletes the absorption of vitamin B12. For this reason, many guidelines would suggest measuring metformin annually after a certain amount of time they have been on it. And it's also important to note that vitamin B12 deficiency can lead to a neuropathy. So if a patient has been on metformin for multiple years, and of course they'll have type 2 diabetes and they're now presenting with neuropathy, it's always a good consideration to question whether this is a result of a B12 deficiency. Now it's quite interesting, there is some evidence that suggests taking calcium supplements can prevent or even reverse this vitamin B12 deficiency. So we've discussed the cons to prescribing metformin. There are certain situations where it shouldn't be prescribed, and that would be in severe liver disease or patients with alcoholism. This is because lactic acid will be raised in liver failure, as well as the risks for interaction with chronic alcohol consumption. In heart failure, which is stable, metformin can be prescribed, but in unstable heart failure, there's the risk for poor perfusion. There's no equilibrium, and therefore we would suggest withholding it or not starting it at that time. As we said, in states of hyperperfusion, there's a heightened risk for lactic acidosis, and we don't want to add metformin onto that. I've mentioned something called mitochondrial diabetes. This is also known as maternally inherited diabetes and deafness. And as it says in the name, this comes from the mother. Everybody inherits the mitochondria from their mother, and ultimately this was derived from Eve, from Adam and Eve. Now, why it can't be prescribed in this form of diabetes? Well, metformin acts within the mitochondria, and that's what leads to the lactic acidosis. So when they already have a mitochondrial disease, there's already a heightened risk for lactic acidosis. So we don't want to add those two together for a heightened risk. Now, here it says iodinated contrast, and that could be a situation such as someone has a pulmonary embolism and they require a CT scan with contrast. Again, this would increase the risk for lactic acidosis, so we would typically withhold metformin for 24 to 48 hours after administering the contrast. With that being said, there are many benefits to metformin. Probably the simplest benefit being how cheap it is. It's been around for very long. It's very easy to obtain. Other benefits, it's weight neutral or even a mild weight loss. And again, when most patients with type 2 diabetes are overweight, we don't want to add a medication that would make them more obese or overweight. It has quite a significant effect on the A1C reduction, about 1 to 2%. In the United Kingdom Prospective Diabetes Study, the UK PDS, and its subsequent follow-up, it was noted that metformin actually had a cardiovascular benefit, less macrovascular outcomes in patients with metformin at diagnosis. There's certain evidence, and this is really in the last few years, that it may have some anti-neoplastic effects. It may decrease the risk of developing cancer. We know that in type 2 diabetes mellitus, they are at high risk for development of cancer. And there's some evidence, again, that it might have a mild anti-inflammatory effect. What's very important is that metformin does all of this without causing hypoglycemia, and that's a fear for both clinicians and for patients. Another important finding from metformin is that it's been around for so long, it's well studied, it is used safely in pregnancy and breastfeeding. So there's other things to note about metformin, and a few things I like to mention is that metformin actually is not metabolized. It's eliminated in the urine as a parent drug, and that's a very common examination question one may find. Also, for reasons which are slightly unclear, it appears as if when starting metformin, the TSH, that's the thyroid stimulating hormone level, may actually decrease a tiny bit. That's also something seen with corticosteroids, somatostatin analogs. We don't know the reason for this, but it's very interesting and again makes for a unique examination question. There's also other rules that metformin may be prescribed, and of course these are more off-license. We know in the diabetes prevention program that patients taking metformin actually, it did help prevent the progression from pre-diabetes to diabetes. And the ADA has certain criteria for when to prescribe it in pre-diabetes. Of course, we know that exercise is the most beneficial in that cohort. In patients with polycystic ovarian syndrome, also known as PCOS, metformin is commonly prescribed as well. As we know in PCOS, there's typically insulin resistance. Something called double diabetes as well. These are patients with type 1 diabetes who eventually become resistant to the insulin, and it's a mixture of type 1 and type 2. And prescribing metformin will improve the insulin sensitivity. Now, we've mentioned metformin can be used in diabetic patients who are becoming pregnant. It can also be used in patients without diabetes who subsequently develop it during pregnancy, something known as gestational diabetes. And there's also some evidence to suggest it may be beneficial in Fragile X syndrome. But again, these are off-license prescriptions. So it's important to be aware of the multiple benefits that will be seen here. So I'd like to mention a bit more about the United Kingdom prospective diabetes study. And as we said, it noted a cardiovascular benefit, both within this and the follow-up study. And this noted that there was a reduction in the risk for macrovascular complications in the metformin group. There's also a reduction in all-cause mortality. And it's very important to be aware of that. There's also certain findings with metformin that it may reduce the serum triglycerides, it may reduce the LDL cholesterol, and it may increase the HDL cholesterol levels. So all very important considerations. So let us discuss the sulfonylurea class of medications. This medication is categorized based on first, second, or third generation. The only third generation is glimepiride, of course. It's also categorized depending on how short or how long acting it is. So we have short acting, intermediate acting, and long acting sulfonylureas. So let's take a look at how this medication works before we understand its principles and applications. So this is the pancreatic beta cell. Normally glucose enters through something called GLUT2, and this is the glucose transporter for that cell. When glucose enters a cell, it's metabolized. As we know, we get our energy from glucose, and ATP is released as a result, adenosine triphosphate. Now, this is energy. Under normal conditions, ATP leads to the opening of the potassium channel. This is also known as the KIR 6.2 inward rectifier potassium channel. And when this channel opens, potassium effluxes or leaves the cell. So if we look over here now, the sulfonylurea binds to a subset of the receptor, and this is known as the sulfonylurea receptor, or SUR1. So when binding to SUR1, it prevents the opening of the potassium channel, and potassium cannot efflux, it cannot leave. So therefore there is an intracellular buildup of potassium. Now what happens when there's an intracellular buildup of potassium? There will be a depolarization of the membrane, and as a result of depolarization, this opens up the L-type voltage-gated calcium channel, and calcium influxes or goes within the cell. So again, Sulfonylureas block the opening of the potassium channel. Potassium cannot escape. Potassium builds up within the cell depolarization occurs, and calcium comes into the cell. Now, insulin is released in two ways. There's the first phase, whereby insulin that has already been synthesized and formed, but is being stored, is released, followed by insulin being synthesized on demand. So calcium comes into the cell and leads to a release of insulin. It's very important to be aware of this application because now we can understand why this should not be given in type 1 diabetes. You would be giving a sulfonylurea to a non-functioning beta cell. It would have zero effect. Whereas in type 2 diabetes, we know there are functional beta cells, but they are rather resistant. The insulin rather is resistant in patients, and we need to push the cells to produce a bit more. Again, though, with the understanding the etiology of type 2 diabetes mellitus, we know that over time the disease does seem to progress and the beta cells become more and more exhausted. So this isn't a one treatment fits all approach. It is very likely that after a few years, the patient will have less response in the sulfonylurea and may not even have any effect depending on how severe their diabetes is. Now, I did mention the KIR 6.2 potassium channel and the SUR1 sulfonylurea receptor. Now, why I mention those is because you can have a mutation of either of those two, the potassium channel or the sulfonylurea receptor, and that's known as neonatal diabetes. There can either be a transient or a permanent hypoglycemia. And it's quite interesting to be aware. That's a result of a mutation in these channels. So going back to a sulfonylurea, these do increase the release of insulin and therefore lead to potential for hypoglycemia. So as a result, it is recommended to use the shorter acting versions or the ones that have a lower risk for hypoglycemia. Those ones include glipizide, which is also known as glucotrol, glimepiride, also known as Amaryl, and gliclazide, also known as diamicron. And these are started at their various dosages and they're increased to a maximum depending on that drug. What's beneficial about these medications is that it is once a day dosing, which is very likely to improve compliance in such patients. It also leads to a substantial reduction in A1C, 1 to 2%, as we've said over and over again. Most medications will not go beyond this except for insulin and possibly the glucagon-like peptide 1 receptor agonists. Another benefit is that these are very cheap. They were discovered in the 1950s, so it's been quite some time, as has metformin. And if you remember the ADA guidelines, and I said specifically to ignore the right-hand side of the screen, but this was under the pathway when cost was an issue, as were the TZDs, or Thiazolidinediones. What's also interesting to note is that glyburide, which is also known here with multiple names, is used in gestational diabetes mellitus. So again, glyburide, a sulfonylurea, can be used in gestational diabetes mellitus, as can metformin, as can insulin. So those are some benefits, but what about the drawbacks? Let's start off with everybody's concern, and that is that when you're releasing insulin, you're going to have weight gain, and patients do not appreciate that. Many of these patients are already overweight. Another thing, of course, we're releasing insulin is a high risk for hypoglycemia, and again, patients are scared of this, physicians can be scared of this. I've mentioned that there's a waning effect over time as the natural progression of type 2 diabetes. It's also important to note that there's no cardiovascular protection from these medications. If we follow the ADA guidelines, remember on the left-hand side it said ASCVD, atherosclerotic coronary vascular disease. If that was present or patients at risk, we would give a glucagon-like peptide 1 or GLP-1 receptor agonist. These medications don't appear to have any cardiovascular benefit. Early medications such as glibenclamide had shown something called ischemic preconditioning, which was a very big concern, and tolbutamide as well was thought to increase CVD mortality in one study many years ago. But for the most part, the sulfonylureas actually don't seem to increase mortality or cardiovascular disease. They also don't seem to protect it from it, however, so we would say they're CV or cardiovascular neutral. This was shown in a study which was known as the Carolina study, and it compared a dipeptidyl peptidase 4 inhibitor to a sulfonylurea, and it showed that there was no increased risk of cardiovascular concern or cardiovascular events with the sulfonylurea. In this case, it was the glimepiride when compared to linagliptin. So again, it doesn't seem to have a cardiovascular concern, but rather there's no benefit. And if a patient has cardiovascular disease, we want one with benefit. Other considerations are that sulfonylureas are highly protein bound, and there's the concern that other medications such as salicylates, which are protein bound, could push more sulfonylurea off of the protein into the serum, making it active, and there's a high risk for hypoglycemia. There's also the concern that sulfonylureas can give skin or allergic reactions to patients. That is rare, but again, something to be aware of, as can it cause abnormal liver function tests, something to be aware of course. Now, these medications, chlorpropamide, actually are unlikely to be used nowadays, as we see the first generation sulfonylureas. However, they make fantastic board questions. Specifically, chlorpropamide leads to something called SIADH, or syndrome of inappropriate antidiuretic hormone release. Something to notice on a examination, as you'll be guaranteed to be asked this question. Similarly, chlorpropamide can lead to a disulfiram-like reaction. Disulfiram is a medication used to treat alcoholism, and it prevents the full metabolism of alcohol. So there's the intermediate metabolite buildup, which leads to the horrible hangover symptoms. And when patients drink and they feel horrible as a result, the hope is that they would stop drinking. Of course, it's a very poor efficacy in terms of stopping alcoholism because it doesn't treat the underlying cause, but chlorpropamide has been found to cause this effect. And again, that's a board examination favorite. So cautions and contraindications to this. So we need to be aware that this sulfonylurea class of medications is part of the sulfa family class, and many medications with sulfa, specifically antibiotics such as sulfamethoxazole or sulfasalazine, which can be used in inflammatory bowel disease. There's always concern that there's a cross reaction in terms of sulfa allergy with this class of medication. The data is starting to show it's actually less likely, less prevalent than we thought, that there would be a crossover between a true sulfa allergy and having a reaction with sulfonylureas. Certain medications are now actually taking that off their box as a warning. Some of them still have it there, but it's important to be aware that this is likely changing. Again, these medications lead to the release of insulin. If there is any sort of kidney failure, the medication will be in the system for much longer. Many of the medications have active metabolites and will lead to a higher risk of hypoglycemia, so it's important to be aware of this. Furthermore, this is another exam favorite question, and is that sulfonylurea shouldn't be prescribed in someone with porphyria because there's a heightened risk for flaring up their porphyria. We've discussed it is inappropriate to give this in type 1 diabetes mellitus, and as this medication is taken once a day, it's assumed patients will eat the regular 3 meals a day. But when they're skipping meals or fasting, for example, then they will have a heightened risk for hypoglycemia. And moreover, when we're exercising, our bodies push glucose into our muscles without insulin effect. And after exercising, we're actually at a heightened risk for hypoglycemia. The last thing here is the concept of driving. When patients are prescribed this medication, depending on where they live, they need to inform the driving or vehicle agency because they are at a heightened risk for hypoglycemia. And this is also important with truckers, heavy good vehicle drivers, that potentially their policies for their employment would not allow them to be on a medication which causes hypoglycemia. So let us move on to the next class of medications. And we have the meglitinides here. So the meglitinides, I like to think of them as a more modern version of the sulfonylureas. They act in a similar fashion to the sulfonylureas. They are slightly different in their chemical structure, and they also bind to an alternative site on the SUR1 receptor. So they have the same effect overall, however, and that is pushing insulin out from the pancreatic beta cell. These medications are quite fast acting and act for a short duration of time, and therefore we use these about 30 minutes before a meal, and they're used to combat the postprandial hyperglycemia. So Because these medications are taken right before a meal, there is the, of course, problem that they require multiple daily dosing, which can be perhaps a barrier for some patients with poor compliance. That being said, however, as I said on the previous slide, sulfonylureas will require just one daily dosing, and as a result, there's a high risk for hypoglycemia if a meal is skipped. It's not necessarily the same with a meglitinide. This is more appropriate with patients having an erratic eating pattern, and if they're only going to have one meal a day, then they'd only take this once a day. If they're only going to have 2 meals a day, my apologies, they're going to take this twice a day. So it's different from the sulfonylureas. Now, there are two types of meglitinides currently available: repaglinide, also known as Prandin, and nateglinide, also known as Starlix. Now, these are more or less the same. They are taken 30 minutes before a meal. However, there was one meta-analysis. A meta-analysis is a grouping of multiple studies, and it found that there's better reduction in A1C when using repaglinide over nateglinide, and therefore it's more recommended to use repaglinide if this class of medications is to be prescribed. Another important finding is that repaglinide undergoes hepatic metabolism and is actually safe in chronic kidney disease. And then we know diabetes can cause kidney damage, lowering of the EGFR, increase in the serum creatinine, and therefore, if someone has chronic kidney disease, they could use repaglinide. So it's important to be aware of. Okay, so let's discuss the benefits. As we've said, erratic eating pattern. It can lower the A1C by about 0.5 to 1.5%. What's also important here is that there's no cross-reactivity with sulfa allergy, whereas the sulfonylurea slide, we discussed that there may or may not be. The data is starting to show perhaps we were too cautious at first. There's no risk of cross-contamination. So if someone has a sulfa allergy and refuses to take a sulfonylurea, they can safely take a meglitinide. That being said, there are multiple drawbacks I'd like to mention. As we discussed, the multiple daily dosing can be an issue, unlike the sulfonylureas, which were given once a day. When insulin is released, obviously there's the inevitable weight gain, which patients would not be too happy with. As these medications are much newer than the sulfonylureas were discovered in the 1950s. They're actually much more expensive. Another thing to be aware of. Now, there are case reports, and many patients do complain after taking the meglitinides of headaches, dizziness, upper respiratory tract infection symptoms, such as nasopharyngitis. And it's for this reason that patients should be made aware of this beforehand in case they experience them. Moreover, as this class of medications is relatively new, we don't know the long-term efficacy, let's say 40, 50 years from now, what these medications do. And that's something to keep in mind. Moreover, as we mentioned on the previous slide, the sulfonylurea class of medications appear to be cardiovascular neutral. No increased risk of damage, no protective benefit when combating cardiovascular disease. There really aren't enough trials to say what meglitinides do in respect to cardiovascular disease. As I mentioned on the previous slide, it's pretty much the same. The cautions and contraindications we should let patients know when they're driving, when they're skipping meals, when they're exercising. Another thing, however, is that because these medications are new, we really don't know the effects during pregnancy and lactation, and that's something to keep in mind. So let us move on to the next class of medications. Let us talk about the next class of medications, the Thiazolidinedione, or TZD for short, as that's quite a tongue twister to pronounce. So this class of medication is quite interesting. There's currently only one medication you will see commonly within practice, and that is pioglitazone, the trade name of this being Actos. And the reason for this is there were two other medications that were withdrawn about 20 years ago. There was rosiglitazone, and this was shown to increase heart failure, increase the risk for cardiovascular events, and in most countries it was withdrawn from the market. It's important to note it's actually still available in the United States. It hasn't been withdrawn, but it's just very, very difficult to find, and you will likely never see it within your training. The other medication in this class is known as troglitazone, and this was withdrawn everywhere in 1999 to early 2000 because it had demonstrated in its patients severe hepatotoxicity. Okay, so going back to pioglitazone, however, this medication comes in 15 milligrams, 30 milligrams, and 45 milligrams. Now I've put that in brackets, the 45 milligrams, because the higher the dosage, the greater the side effects. And a notorious side effect of Thiazolidinediones, or TZDs, is fluid retention, edema. In patients with heart failure, as an example, this medication would be contraindicated because of the worsening of heart failure. So going back to why I put 45 in brackets, most patients tolerate 15 to 30 milligrams, and it's best to start low and go slow. Regarding the pioglitazone and its fluid retention, it appears to be a RAS activator, a renin-angiotensin-aldosterone system activator, and there's some evidence that giving this medication at night, as it's a once daily pill, will reduce the edema. So that is something to keep in mind. Let us consider what exactly the TZD class of medications are and how they work. So if we are to take a look at this diagram, we see pioglitazone acts within a PPAR gamma receptor. A PPAR gamma is a fancy way of saying the peroxisome proliferator activated receptor, or shorthand PPAR, subunit gamma. And when it binds this receptor, it appears to interact with the retinoid X receptor. This cross-reactivity leads to an alteration and transcription of our DNA, and there's enhanced expression of various genes, one of the most important being GLUT4, which is a glucose transporter predominantly within the muscle, and it can also be found in adipose tissue. There's also an increase in fatty acid transporter protein and lipoprotein lipase. In addition to this, there's many other actions such as decreasing inflammatory molecules. We know that type 2 diabetes is a background pro-inflammatory state, and that it contributes to the insulin resistance. So all of these effects within this medication acts throughout the body in various tissues, such as the adipose tissues, skeleton, skeletal muscle, liver, within the vascular endothelium. And as we've said, all these effects appear to enhance the sensitivity of insulin and reduce the inflammation and increase lipid storage. So one thing about pioglitazone in particular, while the other medications are pure PPAR gamma agonists, pioglitazone appears to have an effect also upon the PPAR alpha receptor, and this may partially explain why there seems to be a favorable lipid profile with this medication, which we'll talk about in a moment or so. So let's go back to the benefits now for pioglitazone. I've mentioned it's a PPAR gamma agonist with some PPAR alpha activity. PPAR alpha is a receptor targeted by certain classes of medications known as the fibrates, which aim to reduce the triglyceride levels. And why this is important, because as a result, with this medication, you will likely see the reduction in triglycerides. You may see an increase in the HDL cholesterol, which is our good cholesterol, and the LDL cholesterol doesn't seem to be altered. It may go down a tiny bit, but it is more likely to remain constant. Now, it's interesting to note when pioglitazone is combined with one of those fibrate medications, a PPAR alpha agonist, for example, fenofibrate, there's actually a paradoxical reduction in HDL cholesterol, and that's something to be aware of as it is a very, very common board question. So benefits of a TZD such as pioglitazone, there's a substantial reduction in the A1C. As we've said over and over again, most medications will reduce the A1C by up to 2%. Again, TZDs do not cause hypoglycemia, and that is a major benefit as many patients and physicians prescribing medications are scared of hypoglycemia in patients. If we refer to the ADA guidelines, we remember on the right-hand side if cost was an issue, we should consider prescribing a sulfonylurea or a TZD. There is some evidence that pioglitazone specifically led to a reduction in major adverse cardiovascular events or major adverse atherosclerotic cardiovascular events. There was something known as the PROACTIVE study, which showed that perhaps pioglitazone can reduce macrovascular outcomes. It also appears that pioglitazone is favorable in patients with fatty liver disease or non-alcoholic fatty liver disease, non-alcoholic steatohepatitis. It seems to improve and theoretically reverse what has occurred, and that can be even in patients without diabetes. Within the TZD class of medications, there was some evidence that, like metformin and exercise, that led to thiazolidinediones can lead to a prevention of the progression from prediabetes to diabetes. Of course, we always recommend exercise, as that is the most effective. Exercise leads to a near 58% reduction in the risk of progression from prediabetes to diabetes. So, with this in mind, what's not written here is recent evidence that's coming out suggesting pioglitazone might actually be beneficial in psoriasis as well, and that's quite an interesting notion to be aware of, the extra diabetic benefits from this medication. But if we look at the drawbacks of pioglitazone, we note that there's weight gain, and this occurs because of the enhanced insulin sensitivity and the increased lipid storage. So again, many patients are already overweight. They're going to be quite distraught at knowing this medication will increase their weight. Now, I've put a question mark in front of bladder cancer because the evidence is very mixed. Some studies demonstrate there's an increased risk of bladder cancer. Some demonstrate there's no benefit. Sorry, my apologies, there's no increased risk. We really don't know at the end of the day. So in someone with a past history of bladder cancer, in someone who's presenting with unexplained blood in the urine, known as hematuria, it would be inappropriate to prescribe this medication. There also appears to be an increased risk of osteoporosis in patients taking this medication. And with osteoporosis, there's an increased risk for fractures. So in the postmenopausal female who is osteoporotic, we may recommend prescribing another medication other than the TZD class of medications. Now, there also appears to be a slight increased risk of pneumonia. It's very little, and I would say that's clinically insignificant. There does appear to be an interaction with oral contraceptives. Patients who are taking oral contraceptives should be advised to ensure that there is a second form of contraception available. Now, as I've said, with the medication, the thiazolidinediones, they increase the fluid retention. This can lead to peripheral edema. When this is combined with other medications such as NSAIDs, gabapentin, or insulin, there can be significant edema, and therefore, when there's a combination between a TZD and insulin, it's recommended to actually reduce the dose of TZD or stop it. Now, the data also shows that the edema can be found in the eye, leading to macular edema. And again, if someone has a past history of macular edema, we're not going to prescribe this medication. It would be inappropriate. Something else that does appear in the literature very rarely, and it's difficult to say if this is an association or causation, is the notion of dilutional anemia. So the increased fluid retention within the blood vessels, leading to a decrease in the hemoglobin, in the platelet count, etc. That's something to be aware of in case it's asked on a examination. So we've discussed most of these contraindications. Another thing to be aware of is that it really isn't too well studied during pregnancy and lactation. This medication undergoes hepatic metabolism, so when there's liver failure, it would be contraindicated. It can be used in mild renal failure. It really depends on the degree and the dosage the patient's on. The reason why perhaps some would be hesitant to prescribe this in renal failure is because in renal failure on its own, there will be fluid edema, and this could theoretically worsen it. Now let us move on to the next class of medications. Okay, so now let us talk about the SGLT2 inhibitors, also known as the sodium glucose cotransporter 2 inhibitors. So this is a novel and interesting class of medications. If we start off with the currently available medications in this class, we can see there's empagliflozin, also known as Jardiance, canagliflozin, Invokana, there's dapagliflozin, also known as Farxiga, there's ertugliflozin, also known as Steglatro, and sotagliflozin, also known as Zynquista. And I will come back to discussing sotagliflozin, and it appears to be slightly unique and different from the other ones mentioned. But what is the SGLT2 and why is it extremely beneficial in type 2 diabetes mellitus? So this is a diagram of the nephron in the kidney. This is the proximal convoluted tubule, and we see there's SGLT2 and SGLT1. So SGLT2 is present more proximally than SGLT1, and it's responsible for about 90% of the glucose reabsorption within the PCT, or proximal convoluted tubule. And SGLT1, of course, is responsible for the remaining roughly 10% and is also present in the intestine. So normally we all have a threshold of about 180 milligrams per deciliter, whereby above this glucose appears in the urine, and this is known as glycosuria. When we take this medication, however, it inhibits the reabsorption of glucose, and there's excess spillage of it into the urine, and this contributes to the reduction in blood sugars and decrease in A1C. Now, this is only one of the important mechanisms responsible for SGLT2 inhibitors. They also appear to reduce the hypertension, the interglomerular hypertension, and this appears to be nephroprotective, reducing the damage imposed by diabetes upon the kidney. It also appears to, as a result, decrease the blood pressure, and this decreases the stiffness of the arteries. As a result, there's furthermore a decrease in remodeling of the heart, there's decrease in preload and both afterload, and hence a decrease in the risk for hospitalization for heart failure. So it's important to note, once again, the SGLT2 inhibitors have an effect beyond the A1C. So apart from decreasing the sugar levels of the blood, they have all these other effects we've just mentioned. Now it's important to note that SGLT2 inhibitors have both effects going concurrently, the reduction in blood sugar and the other effects such as the kidney protection and reduction in heart failure. But below an estimated GFR of 45 milliliters per minute, they appear to have less glycemic effect. They may still be nephroprotective, they may still have an effect upon heart failure. But if you're prescribing a medication below this eGFR, you need to make sure you have a second medication to combat the glucose levels, as it really won't do much in terms of the A1C reduction. So going back up here to sotagliflozin, the reason I have highlighted that is because all these other medications are pure SGLT2 inhibitors, whereas sotagliflozin is actually a dual SGLT2 and SGLT1 inhibitor. So that means sotagliflozin also inhibits SGLT1 within the intestine. In the European Union, sotagliflozin is actually approved for type 1 and type 2 diabetes mellitus, but the FDA, Food and Drug Administration in America, has only approved it for type 2 diabetes, but it's something to be aware of in case it does change. Now, I'm not going to go over the dosing here, but I just wanted to show this is something that is followed in the European Union. This is where I studied, and this is what my understanding of the dosages were in certain situations. Of course, it's typically guideline and institution specific, and it does constantly change. But as you can see, there's different dosages depending on the eGFR and the reasons for prescribing it, whether it's for kidney protection, whether it's for glycemic control. So there's multiple benefits to the SGLT2 inhibitors. Quite notably, they lead to weight reduction, and that's something, of course, as we've said, patients with type 2 diabetes mellitus are typically overweight. About 85% of patients with type 2 diabetes are overweight, but only 15% of people who are overweight or obese have type 2 diabetes mellitus, so weight loss is highly beneficial. It leads to a decent reduction in A1C. As we know, it has multiple effects beyond the A1C, as we say. It appears to have a favorable lipid profile, so it can reduce the triglycerides, it can increase the HDL cholesterol as well. As we know, it's beneficial in heart failure, and even in patients without diabetes mellitus, the SGLT2 inhibitors, particularly dapagliflozin, also known as Farxiga, appears in the recommendations, the algorithm for its management. We know there's cardiorenal protection, and if we remind ourselves of the ADA guidelines on the left-hand side of whether it was ASCVD or heart failure or CKD, SGLT2 inhibitors appeared. We also know as a result of this reduction in preload and the decrease in stiffness of the arteries, there's a reduction in blood pressure. As a result of a decrease in the stretching of the vessels on the heart, there's also a reduction in the risk for arrhythmias. So another finding you will see on this medication is a reduction in the serum uric acid. So there are a few drawbacks to this medication. The first is there's a strange concept which has gained more attention recently, known as euglycemic diabetic ketoacidosis. It appears that the SGLT2 inhibitors in certain susceptible individuals may actually precipitate diabetic ketoacidosis, likely because how this medication works is it increases the glycosuria. As a result, water follows, and patients can become severely dehydrated. Because they're urinating excess glucose, they may have relatively normal glucose levels on presentation. It also appears that the SGLT2 inhibitors increase the absorption and recycling of ketone bodies. Euglycemic DKA is something you will also see in pregnancy, but that's for another talk. Now it's a bit strange. Canagliflozin, or Invokana, noted an increased risk of lower limb amputations and fractures. It appears to be only relative to that medication, and that's a reason why many physicians would not prescribe that drug. Unfortunately, although the SGLT2 inhibitors reduce triglycerides and increase the HDL cholesterol, they also promote a mild increase in LDL cholesterol, which is something to be aware of. It's not typically that clinically significant, but important to be aware of. Again, these medications are relatively new, less than 10 years old, and they're quite expensive. Now, because there's excess urination of glucose, there's an increased risk of genital fungal infections, Fournier's gangrene, which is a type of necrotizing fasciitis of the perineum, and urinary tract infections. Sometimes we do tell patients if they are known to easily get fungal infections, such as thrush, to have some yogurt the night before, or which has probiotics in it. Again, when there's excess urination out, there can be hypotension as a result. Patients can be severely dehydrated. Dehydration can lead to acute kidney injury, and sometimes you may see as a result electrolyte abnormalities such as hyperkalemia, hypermagnesemia. Another finding gaining recent attention is the concept of erythrocytosis, or increase in the blood hematocrit, likely as a result of severe dehydration. Now, it's a bit unclear regarding bladder and breast cancer. Some studies have shown that the SGLT2 inhibitors make a pre-existent bladder or breast cancer more readily apparent. It's unclear whether it causes it. It's very unlikely to, but more likely it makes a already established or background cancer more noticeable. And for this reason, if they have a history of either of these, it's best to avoid it. Now, there are some contraindications to SGLT2 inhibitors. For the most part, it's not a contraindication, but rather a caution if patients have type 1 diabetes or they have atypical forms of diabetes where they're at risk for going into ketosis. As we know, the sotagliflozin medication is approved for type 1 diabetes in the European Union, and it's likely to change if we prescribe SGLT2 inhibitors in the appropriate individual with some kidney damage. Perhaps the benefits outweigh the risks. Again, if they're at risk or have foot ulcers or neuropathy, it's best to consider another medication. And again, as these medications are relatively new, it's really unknown the effects of pregnancy and lactation. Now, something unique about this class of medications is actually how it was initially discovered. In about the year 1835, florazin was discovered from the apple root tree bark, and florazin is known as the first non-selective SGLT inhibitor, which led to renal glycosuria. So it's quite interesting to note this medication was actually found from an apple tree. So let us move on to the next medication. So before I talk about the next two classes of medications, I would like to discuss something known as the incretin effect. So what is the term incretin? It refers to two gut hormones in particular, glucagon-like peptide 1 and gastric inhibitory peptide, also known as glucose-dependent insulinotropic polypeptide. For shorthand, this is referred to as GIP. So what does this have to do with diabetes? The incretin effect refers to the enhanced release of insulin after an oral glucose load compared to an intravenous glucose load of the exact same quantity consumption. And we can see here that's demonstrated in this graph. Having an oral glucose load compared to the same intravenous glucose load will lead to greater insulin release, and that is known as the incretin effect. In type 2 diabetes mellitus, there's some evidence that the incretin effect is actually diminished, and that's how it relates to type 2 diabetes mellitus. So what is GLP-1? That's a hormone released from L cells of the small intestine, and despite its name, it actually inhibits the release of glucose. It slows the gastric emptying, and it enhances the release of insulin at appropriate times. We call it a smart molecule because it doesn't constantly lead to a secretion of insulin, as do sulfonylureas. GIP-1, I like to think of it as the smarter twin. It does lead to an induction of insulin secretion at the appropriate time, but during fasting states, it actually does the opposite and enhances glucagon activity. So it appears to lead to that equilibrium, that balance. So these hormones are degraded by the enzyme DPP4, dipeptidyl peptidase 4, and we will talk about how this relates to medications in a moment. So again, incretin effect, there's a greater oral stimulation of insulin release compared to an intravenous stimulation. Okay, so the next class of medication we will discuss are the DPP4 inhibitors or dipeptidyl peptidase 4 inhibitors. As we've just discussed on the previous slide, this medication inhibits the enzyme DPP4, preventing the degradation of GLP-1 and GIP. DPP-4 inhibitors lead to roughly 2 times the levels of normal GLP-1 and GIP. Now, as we've already discussed on the previous slide, what GLP-1 and GIP do, they slow gastric emptying, induce satiety, the feeling of fullness, decrease the secretion of glucagon, and promote the release of insulin. The current available DPP-4 inhibitors are sitagliptin, linagliptin, saxagliptin, vildagliptin, and alogliptin. Again, the trade names are written here for your own learning. I've put linagliptin in yellow here, I've highlighted it, and I'll come back to it in a moment as to why. But as we can see, these are once daily dosing. It's a stable dose, and patients will appreciate this being once only, improving their compliance. Now, I've stated here there's no association with COVID-19. At the beginning of the pandemic, there were lots of studies coming out saying, oh, there's a protective effect, oh, it's actually detrimental, you shouldn't prescribe it. And really, we have enough data to say there's actually no relationship with COVID-19, and you should not prescribe this medication for or against the reasons for SARS-CoV-2. That would be highly inappropriate. So we stated already, levels are increased by 2 times normal. We'll talk about GLP-1 receptor agonists on the next slide, but they actually increase the levels by roughly 9 to 10 times. And it is important not to combine a DPP-4 inhibitor with a GLP-1 receptor agonist. The reasons being you will see no further benefits. You'll actually see more adverse effects. There'll be worsening GI side effects, and patients will be very unhappy and likely stop taking their medications. So about the DPP-4 inhibitors, they have a modest reduction in the A1C by about 1.0%. What's very beneficial is they have little to no drug-drug interactions. And of course, we know patients with type 2 diabetes mellitus are likely to be on more than one medication. These drugs are weight neutral, so it does not increase the weight of patients. That's beneficial. As we've stated, most patients with type 2 diabetes mellitus will be overweight or obese. And again, this class of medication does not cause hypoglycemia. That is very beneficial. Patients and physicians are scared for hypoglycemia. So there's also some evidence recently coming out suggesting perhaps DPP-4 inhibitors reduce albuminuria. There's no evidence to suggest this is beneficial or this is nephroprotective or reduces long-term macrovascular outcomes. So for now, you should not prescribe it for this sole reason. So when would I prescribe a DPP-4 inhibitor? Well, from what I've seen, what I would typically do is, let's say there's a young patient, recent diagnosis of type 2 diabetes mellitus, they're taking metformin, perhaps they need something just a tiny bit more added onto metformin to get their A1C down to below 6.5 or 7%. In this case, they have no nephropathy, no past history of ASCVD, no kidney problems, no heart failure, they're not at risk for hypoglycemia, and they can afford the medication or they have good insurance, then I would consider this medication. So there are some drawbacks I'd like to mention. The first being it's quite new, and as I said, if they can afford it or if they have good insurance, because it's quite an expensive medication being relatively new. Again, a lot of case reports have now come out saying there's a risk of developing bullous pemphigoid, which is an autoimmune skin condition as a result of this class of medications. It's quite rare, and you should not withhold this medication just because of this rare concern. Many patients complain of viral-like or flu-like symptoms after starting this class of medications, things such as nasopharyngitis, arthralgia, which is joint pain, muscle pain, headaches, symptoms like a upper respiratory tract infection. And it's important to make these patients aware of this before prescribing it. Otherwise, they will present to your office very concerned they have developed an infection or even COVID. Okay, so make them aware of this beforehand and save them the embarrassment. As with this medication increasing gut hormones, there's many GI side effects such as nausea, vomiting, diarrhea, or even constipation, and patients should be made aware this is likely transient and will improve as they keep taking the medication. Angioedema, it's actually a rare side effect of this class of medications. If we think about the angiotensin converting enzyme inhibitors or ACE inhibitors, they inhibit the breakdown of bradykinin, and there's excess bradykinin levels, higher risk for cough and angioedema. And dipeptidyl peptidase 4 inhibitors are actually also involved in inhibiting the breakdown of bradykinin, and there's a greater risk for angioedema, especially when combined for an ACE inhibitor. Now, there are case reports that suggest the DPP4 inhibitors and GLP-1 receptor agonists increase the risk for pancreatitis and pancreatic carcinoma. It's not extremely clear whether this is causation or association, but in patients with a past history of either of these, or if they have recurrent episodes of pancreatitis, it would be inappropriate to prescribe this class of medications. What's very interesting is that this class of medications appears to confer an increased risk for inflammatory bowel disease in the future. That makes a fantastic board or examination question and something to be aware of. As we've stated with the sulfonylureas, they appeared to not have any protection over cardiovascular outcomes, but they didn't appear to be detrimental, and it's the same consistency with DPP4 inhibitors. They appear to be cardiovascular neutral. Again, these medications are relatively new, so we don't have enough data to recommend their use during pregnancy or breastfeeding. Now, cautions and contraindications. Vildagliptin and allogliptin both seem to increase patients' liver enzymes, the liver function tests, and that's something to be aware of when prescribing this. Saxagliptin and allogliptin have demonstrated through certain studies an increased risk for hospitalization of heart failure, so it would be inappropriate to prescribe these in patients with heart failure. All the medications are, it's a single dose once a day, and they require dosage adjustments during renal failure, except for linagliptin. This undergoes the hepatic metabolism and elimination, that's why I put that up here in yellow, linagliptin or Tradjenta. So it doesn't need to have a dosage change during renal failure. As we've mentioned, it should not be prescribed concurrently with the GLP-1 receptor agonists. GLP-1 receptor agonists are much stronger, much more efficacious, and overall just much better drugs. So when we start a GLP-1 receptor agonist, we should stop the DPP4 inhibitor. Finally, these are relatively new drugs, as I've stated. Therefore, we don't know the long-term effects 20, 30, 40 years from now. Okay, now let us discuss the glucagon-like peptide 1 receptor agonists, or GLP-1 receptor agonists. So up to now, apart from insulin, we've been talking about oral medications. GLP-1 receptor agonists are actually subcutaneous injections. They're given either daily or once weekly. Now, as we've stated, we do not combine these with the DPP4 inhibitors. We typically stop the DPP4 inhibitor when starting these medications, as GLP-1 receptor agonists are more beneficial overall across almost every domain. Now, besides from the side effects, if we were to combine a DPP4 inhibitor with a GLP-1 receptor agonist, another reason why it would be quite frankly useless is the finding that GLP-1 receptor agonists are synthetically created to be resistant to DPP4, and hence there would be no benefit of giving DPP4 inhibitors, as these drugs are naturally resistant to the degradation anyways. So these drugs increase the levels of GLP-1 by roughly 9 to 10 times that of normal, and the drug goes throughout the subcutaneous tissue, slowly released within the body, acting within various organs such as the liver, kidney, heart, skin, hypothalamus, pancreas, stomach, intestines, etc. As we've discussed, this leads to stimulation of insulin release. It induces a feeling of fullness or satiety. It slows the gastric emptying, and there's some evidence in animals that this perhaps leads to beta cell replication, but this has not been found yet in humans. It's unfortunate, but we're still looking at this finding. So what I would like to mention first about the GLP-1 receptor agonist is actually how it was discovered. So the first medication was actually exenatide, and how this was discovered was actually from the saliva of a Gila monster. The hormone exendin-4 was found, and it was demonstrated that had about 50 to 53% sequence identity with normal human GLP-1. So from then, we've developed synthetic laboratory, more human GLP-1 receptor agonists. So if we go over the various types now, we can see there's semaglutide, also known as Ozempic. I've put that in yellow because that's probably the most commonly prescribed one, the most well-known, and in my opinion, the most beneficial out of all of them. There's also dulaglutide, which is known as Trulicity, and there's a type of exenatide known as Bydureon. So these are all given once a week as a once-a-week injection, which is likely to improve compliance. Here we can see in the daily injections, there's liraglutide, known as Victoza, there's lixisenatide, also known as Lixumia, there's albiglutide, known as Tanzium, and there's also exenatide Byetta. This one is a twice-daily medication, and it's really going to impair the compliance if patients are requiring this medication to be injected twice daily. So just as an example how we would dose this medication, because of the concern for the significant GI side effects, we would start low, so about 0.25 milligrams, and after 2 to 4 weeks, we would increase that to 0.5 milligrams, and again, we would try to increase that to 1 milligram. It's important to note that apart from Ozempic, which is the diabetic drug of semaglutide, the trade name, of course, there's recently been a drug known as Wegovy, which has been approved for up to 2.4 milligrams for weight loss, and this is simply semaglutide at a higher dosage. The same can be seen with Saxenda, which is liraglutide at a higher dosage. Okay, so what I'd also like to mention quickly is if we go down to the bottom of this page, in the past few years, there's been an oral medication, oral semaglutide, which has been approved, and that's quite amazing. It is a game changer, taken once a day. It is the exact same molecule as semaglutide in the injection pen Ozempic, but rather an oral pill. Currently, there's a new drug under investigation known as tirzepatide, and that's actually a dual GLP-1 receptor agonist, GIP agonist, and it appears to be more beneficial. It's not yet FDA approved, but it seems to be more beneficial in all the effects of the GLP-1 receptor agonists we will talk about in a moment. There's also certain medications which combine a basal insulin with a GLP-1 receptor agonist, so examples are Soliqua and Zoltafy. What's good about these medications is that when insulin is combined with the GLP-1 receptor agonist, we require less insulin, of course, as the GLP-1 receptor agonist cause us to release more insulin. So as a result, we typically see less weight gain on the combination of a basal insulin with a GLP-1 receptor agonist compared to basal insulin on its own. As well, many of my patients would suggest that they have less nausea, less vomiting, less GI side effects when the GLP-1 receptor agonist is combined with basal insulin. Now, the problem with this, of course, being a dual medication, is that the insulin is the rate limiting step in administering these medications. Of course, something to be aware about. Now, finally, I've put in here teduglutide, and that's because I've seen this question many times come up on exams and try to trick students. Teduglutide is a GLP-2 receptor agonist, and this is actually used in short bowel syndrome. So types of questions I've seen, for example, are GLP-1 receptor agonists are efficacious in all of the following syndromes except, and of course, short bowel syndrome will be one of the options because it's not a GLP-1 receptor agonist, it's a GLP-2 receptor agonist used in this situation. So let's go over the benefits and some drawbacks to a GLP-1 receptor agonist. So as I've said, it can lead to quite a modest reduction in A1C. There's some evidence suggesting it can reduce the A1C by more than 2%. And as I said at the start of this video, before we thought only insulin could lower the A1C, that when it's significantly above 9 or 10%, perhaps GLP-1 receptor agonists can as well in certain patients. So compared to the DPP-4 inhibitors, GLP-1 receptor agonists lead to weight loss, and that's very beneficial. As we've said, many patients with type 2 diabetes, most of them will be overweight or obese. Again, like the DPP-4 inhibitors, they do not cause hypoglycemia. It's important to note that when I say they do not cause hypoglycemia, they do not cause it on its own, but any drug mixed with others or polypharmacy, or when insulin is used concurrently, of course, there's a higher risk for hypoglycemia. But if the patient's only taking, for example, a GLP-1 receptor agonist and metformin, they're not going to have hypoglycemia. Certain medications, I've put in the acronym LSD. That's not the recreational drug. That's actually the acronym for liraglutide, semaglutide, and dulaglutide. These have actually shown cardiovascular safety, reduction in all-cause mortality, and certain reductions in major adverse cardiovascular events. And if we think about the ADA guidelines, which I spoke about at the beginning of the video, and on the left-hand side, if a patient is at risk or has atherosclerotic coronary vascular disease, it's one of these three medications that would be prescribed. So there's no licensed indication for nephroprotection at the moment. If we remember on the ADA diagram, if they had CKD, chronic kidney disease, then an SGLT2 inhibitor would be appropriate. Of course, there are situations where an SGLT2 inhibitor would be inappropriate. Perhaps the eGFR is too low, perhaps they're at high risk for ketoacidosis, and in that situation, it's recommended to give a GLP-1 receptor agonist. There's recent data such as the LEADER trial, which has actually shown that the GLP-1 receptor agonists do appear to be nephroprotective and slow the decline in renal impairment. And perhaps in the future this will be a licensed indication. There's also some evidence to suggest that giving exenatide slows down the progression of Parkinson's disease as well as Alzheimer's disease. Alzheimer's disease is colloquially termed type 3 diabetes because it's believed part of the pathogenesis is some insulin resistance within the brain. And it's very interesting to see where this research will take us, if perhaps exenatide would be an approved medication for Alzheimer's in the future. For now, of course, there's not enough evidence to suggest this, but it's something that's being investigated at the moment. Now, I'd quickly like to mention again about the cardiovascular safety. I put semaglutide, but this is the injection, the Ozempic. Although there is the oral semaglutide known as Rybelsus, it's currently still under investigation. The SOUL trial is currently underway, assessing whether there is a cardiovascular benefit. We know from the preliminary data that the oral semaglutide Rybelsus is non-inferior, but we're still waiting to see whether there is a superiority cardiovascular benefit. So if someone has atherosclerotic coronary vascular disease, realistically, it should be the injectable medications or the injectable semaglutide, not yet the oral one. Now, other things to mention, certain drawbacks. As we've said, GI intolerance. Many patients will complain of significant vomiting, nausea, diarrhea, that they will refuse to take this medication. As I've stated, that's why we go slow at a low dose and try to up-titrate it, but of course some patients will just not tolerate it. When patients have severe nausea, vomiting, diarrhea, and aren't keeping fluids down, there is a risk for acute kidney injury. So of course, if patients are suffering with this, they need to present to medical attention to have intravenous fluids to prevent renal damage. But it doesn't appear the medication on its own, if you are tolerating it well, would lead to kidney damage. There's also some evidence that just like any medication, there's a risk for thrombocytopenia. That is rare and should not be a reason to stop or to withhold the medication. Because this injection is this medication is an injection, of course there's risks for injection site reactions and hypersensitivity reactions, but of course this is rare. Similar to the DPP-4 inhibitors, there's a concern that this could cause pancreatitis or pancreatic carcinoma. In patients who have hypertriglyceridemia and perhaps have suffered from pancreatitis in the past, then I would be cautious to prescribe this medication in them. There are certain drug interactions because this drug works by slowing the gastric emptying, therefore potentially increasing the absorption of other drugs. There's a common example given with Rybelsus, the oral semaglutide, and it does make a nice examination question. And they actually found in their study that levothyroxine, which is used for hypothyroidism, or underactive thyroid, is actually increased by roughly 33% when administered, when a patient's also being administered semaglutide. So there is some suggestion perhaps we need to reduce other dosages, but really there isn't enough information at the moment. In the semaglutide studies, they also found there was a transient worsening of retinopathy. It appears to be similar to when given insulin, and there's a rapid reduction in A1C, so something to be aware about. Also, a drawback, of course, these medications are very expensive. If you have good insurance, you're very lucky. Otherwise, it can be costing you hundreds, if not thousands of dollars a month. When there's a weight loss, of course, there's an increased risk for gallstones, and that is something patients may note and something to be aware of. And finally, it appears that in rare circumstances, antibody formation may occur. Most of the studies suggest this is not significant and doesn't seem to affect the drug's action. There's very little studies that do suggest perhaps this does affect the drug action. Now, it's important to note the cautions and contraindications. This medication acts by slowing down gut emptying, and in a patient with diabetic gastroparesis, they already have this impairment in digestion, and it would be very unwise to give a GLP-1 receptor agonist in a patient with gastroparesis. Now, in rat studies, they identified a GLP-1 receptor agonist could increase the risk of medullary thyroid cancer. This has not been demonstrated to occur in humans, but it's nonetheless a black box warning. So in a patient with a past history of medullary thyroid cancer, or even a family history, including multiple endocrine neoplasia, this medication should not be prescribed. I've already mentioned if they have hypertriglyceridemia, they're at risk for pancreatitis, and it would be you should prescribe this with caution. Now, in renal impairment, it appears a bit different in the sense that each medication has its own EGFR, whereby it should be either reduced or not used. For example, exenatide, there's not enough data to recommend its usage under an EGFR of 30 milliliters per minute, whereas the LSD group, liraglutide, semaglutide, dulaglutide, there's some evidence that down to 15 milliliters per minute appears to be safe. Let's now discuss the alpha-glucosidase inhibitor class of medications. So it's important to note these are actually very rarely prescribed outside of Asia. There are multiple reasons for this, mainly being the side effects are just too intolerable for most patients, but it's also more effective in reducing the A1C with a large carbohydrate diet, the type of diet which is most commonly seen in East Asia rather than the Western diets. So let's discuss first how this class of medication works. If we zoom in here, we see the villus, which is in the intestine. If we zoom in further, we have our microvilli, the brush border on the enterocytes, the gut cells. And at this brush border, we have the enzyme alpha-glucosidase, which breaks down complex carbohydrates, which we eat, into monosaccharides such as glucose and fructose. When it prevents the breakdown of this, however, there's the increased carbohydrates, which can be fermented by the gut bacteria, and hence there will be a significant amount of flatulence, diarrhea, side effects, which many patients will not be pleased with. It's important to note this medication is taken before each meal, and as a result, it reduces the postprandial glucose rise, as well as delaying the absorption of sugars, as I've mentioned. So available medications include acarbose, also known as Precose, Miglitol, also known as Glycet, and Voglibose or Volux. So, okay, now that we have this in mind, we have stated it works predominantly through the reduction in postprandial glucose. It's more commonly prescribed in China, and as we said, it's more effective in patients whose A1C is elevated, likely because they have complex digestible carbohydrates in their diet. If you have a low-carb diet, it's really going to do very little for you. Benefits of this: it reduces the A1C modestly by about 1.0%. It's weight neutral. Some evidence suggests there may be a mild weight loss, which of course is much better than weight gain. It does appear to have a favorable lipid profile. Certain studies suggest it can reduce the LDL cholesterol and increase our good cholesterol, which is the HDL cholesterol. And it's even been studied as a medication to prevent the prediabetes progression to diabetes. Of course, as I've mentioned over and over, exercise is the most beneficial, with a 58% reduction in the progression from prediabetes to diabetes. So other important findings. One study actually found that there was a cardiovascular benefit when prescribing this class of medications, perhaps reducing the risk for myocardial infarction. Of course, there's little evidence in this regard, and we shouldn't take just a handful of studies at face value, but perhaps in the future this would be a benefit if it's more widely prescribed and studied. Because of its mechanism of action, it does not cause hypoglycemia, and it's important to note this drug is not systemically absorbed, and it's therefore understood that it is safe in chronic kidney disease. It should be noted, however, that Miglitol compared to acarbose, Meglitinide is more absorbed than acarbose and has a greater amount of excretion by the kidneys, and therefore perhaps in renal failure it would be acarbose to be used rather than Meglitinide. Again, with the improvement in the cardiovascular findings from those handful of trials, the increase in favorable lipid profile, the improvement in glucose, and the improvement in weight loss, perhaps it's not a surprise that this drug also seems to lead to a mild improvement in blood pressure. As I've spoken about, the drawbacks, the most common complaint is the flatulence, which is seen in more than 70% of patients, most of which will discontinue the drug as a result. That's also associated with diarrhea. And acarbose has been shown to lead to a rise in liver function tests. We don't know if this is clinically significant or not, but perhaps in a patient with already abnormal LFTs, you may not want to prescribe this drug, and that should be a caution, so in a patient with liver impairment. Again, this drug is rarely prescribed. There's not enough studies to suggest it's safe during pregnancy or lactation. Furthermore, how this drug works, it requires a normal functioning intestine. So if there's already a pre-existing intestinal disease, it would be unwise to prescribe this medication. Now, final consideration, although I said hypoglycemia is unlikely, if this drug is combined with another drug which can lead to hypoglycemia, it's important to note how to reverse this. Typically, when a patient has hypo episode, we tell them to eat orally ingest something with glucose in it or a complex carbohydrate. In this situation, it would have to be a monosaccharide or a glucagon injection, because how the mechanism of action works, we know that complex carbohydrates would not be broken down while this medication is in our gut, and therefore it would have to be something like an oral glucose tablet. Okay, so that's something to very much make your patients aware of. Now, with that in mind, let us go now to the next medication class. So let us now consider the dopamine receptor agonist class of medications. It might come as a shock to most people watching this video that Cyclocet, the trade name for bromocriptine mesylate, the quick-release version, is actually FDA approved for managing type 2 diabetes mellitus. With that in mind, however, if you recall the first few slides we discussed in this presentation, bromocriptine did not appear anywhere, and it's very unlikely you'll ever see this prescribed for that purpose. So how does dopamine lead to improved insulin sensitivity? So we need to consider the findings that in type 2 diabetes mellitus, there appears to be a decrease in the dopaminergic tone in the early hours of the morning. We know that dopamine is responsible for blocking the increase in prolactin. So when there's a decrease in the dopaminergic tone, we see an increase in the prolactin levels, which appears to lead to an enhanced sympathetic activation. And it's important to note, in the lean individuals, so non-insulin resistant, prolactin appears to peak at nighttime, not during the daytime. But in obese subjects, it appears the opposite. In obese subjects who are insulin resistant, there's increased daytime prolactin, as we stated, from the decrease in dopaminergic tone. So it appears that when there's the decrease in early morning dopamine levels in diabetes, there leads to increased prolactin with an increase in sympathetic nervous system activity, and from this can result increased gluconeogenesis, increased lipolysis, and hence triglyceride levels and free fatty acid levels, and increased lipogenesis, all of which lead to further glucose intolerance, worsening insulin resistance, dyslipidemia, and cardiovascular disease. Now, when we take dopamine, we take the quick-acting version within 2 hours of waking, and what this does is it increases our morning dopamine levels within the hypothalamus. As a result, it decreases the prolactin, and that decreases the sympathetic nervous system activity. As a result, there's less gluconeogenesis, less lipolysis, less lipogenesis, and virtually the complete opposite of what we've seen on the left-hand side. There's better glucose tolerance, improved insulin sensitivity, decrease in fatty acids and triglycerides, and a decrease in vascular pathology and cardiovascular disease. So some benefits of taking this class of medications: it appears to have a modest reduction in A1C of about 1.0%. It is weight neutral. As we've discussed, it's always an important consideration whether a drug increases the weight or not. It does not lead to hypoglycemia. It leads to a reduction in triglycerides and free fatty acids, so a favorable lipid profile. And even one study has demonstrated a near 40% reduction in cardiovascular outcomes. Of course, from one study, we can't make a conclusion that this is a cardiovascular safe medication, but we can suspect this, and through further studies, perhaps it will concur this finding. Some drawbacks. As we know, when patients are taking dopamine agonists, for example, in Parkinson's disease or other conditions, a very common complaint is of headaches, fatigue, orthostatic hypotension, dizziness, and hallucinations. So it's important to consider this. Again, there appears to be GI intolerance, GI side effects, which patients will not appreciate, and there do appear to be certain drug-drug interactions. So it's always important to consider what medication the patient is taking concurrently. As a result of the hallucinations, this is actually a contraindication to prescribe the medication if there's a past psychiatric history, because it could theoretically worsen the psychiatric ailment. Again, this drug is very rarely prescribed and poorly studied, so we don't know the effects regarding pregnancy and lactation. Now let us go on to the next class of medication. Now let us talk about the bile acid sequestrant class of medications. Again, it may also surprise you, the FDA has approved one of these medications, colesevelam, in the management of type 2 diabetes mellitus. Now, it's important to note once again, like bromocriptine, you're very unlikely to ever see this medication prescribed for the purpose of type 2 diabetes mellitus. However, you may see this medication prescribed for other reasons, and it'll have the benefit of improving glucose tolerance and insulin sensitivity. So how this medication works, we're actually not too sure why this medication in particular improves glucose levels and insulin sensitivity. One of the prevailing hypotheses is that it binds to a bile acid receptor known as the farnesoid X receptor, and this appears to have an effect upon decreasing gluconeogenesis and therefore postprandial glucose spikes. There's also some evidence that in type 2 diabetes mellitus, the intestinal microbiome appears to be altered, and this medication may fix that. Again, there's also some evidence that GLP-1 is released from the L cells of the small intestine, increasing their levels, as we know, can improve satiety, slow gastric emptying, and decrease glucagon levels. There's also some further evidence that both peptide YY and oxyntomodulin are secreted in response to this medication, both of which can improve satiety. So this drug can come as either a tablet or a packet. And let's talk about some of the benefits. It has a mild HbA1c reduction by about 0.5%, and that's again why I've stated perhaps this medication will never be prescribed solely for diabetes, but in the setting of other diseases, and a patient also has diabetes, you'll likely see this. There's mild evidence perhaps there's a cardiovascular benefit, like we've stated on the bromocriptine slide. There's very little evidence to make a one-for-all recommendation. Perhaps with more studies, we'll be able to know for sure if there's a cardiovascular benefit. Again, this medication doesn't appear to be systemically absorbed like the alpha-glucosidase inhibitors, and perhaps, therefore, it's not surprising that there are many case reports of using this medication safely in renal, hepatic, and heart failure. How this medication works, as we know, it's a bile acid sequestrant, so it lowers the LDL cholesterol quite favorably. And again, this medication is weight neutral, which is very beneficial. Whilst it lowers LDL cholesterol, however, it actually increases serum triglycerides. So when you have triglycerides of about more than 500, you should not prescribe this medication. And we know in type 2 diabetes, the dyslipidemia we see is typically an increase in triglycerides, again, limiting the appropriateness of this medication. This medication also has multiple drug interactions, and this is because of its effect going through the hepatic and bile duct route. Medications which further go through this route, such as digoxin, may be interfered with. As a result of decreasing the absorption of fats, this also leads to a fat-soluble vitamin depletion, something to be aware of. There's also case reports of a bowel obstruction when taking this medication. As with most medications we've discussed, there seems to be GI complaints such as constipation, nausea, dyspepsia. Again, patients may be intolerant to this. And again, we should warn patients of the potential for nasopharyngitis, otherwise they may come in concerned that they have a new infection as a result. So cautions and contraindications to this medication. If you have any motility disorder of the GI tract or prior surgery or gastroparesis, because of the risk for bowel obstruction, this medication should not be prescribed. What's also very interesting is that depending on the type of medication taken, whether it's the packet or it's the tablet, there appears to be aspartame in it, and aspartame we know is contraindicated in patients with phenylketonuria. So if you have this diagnosis, you cannot take this medication. So with this in mind, let's go on to the final medication. Let us now discuss the final class of medication, and that is the amylin mimetic. This is known as pramlintide or trade name Simlin. Now we need to understand what is amylin. Amylin is a hormone which is co-secreted from the beta cells of the pancreas alongside insulin. It's also important to know, out of all the drugs we've discussed today, apart from insulin of course, amylin or pramlintide or Simlin is the only one which is approved for type 1 diabetes, of course, as well as type 2 diabetes mellitus. Now, why this is not commonly prescribed in type 2 diabetes mellitus is because this drug is only approved in those taking prandial insulin. We know patients with type 1 diabetes require prandial insulin, but not all type 2 diabetic patients will require this. It's important to note that this medication will never replace insulin, but rather it may reduce the amount of prandial insulin required, sometimes by up to 50%. Now, how does this drug work? I like to think of it similar to the GLP-1 receptor agonist. It slows the gastric emptying, it leads to a reduction in the release of glucagon, and it induces satiety. Unlike the GLP-1 receptor agonist, however, amylin mimetics do not induce insulin secretion, but through these various actions, we've already seen that it may lead to a reduction in the dosage of insulin required. So dosages given. In type 1 diabetes mellitus, it's typically 15 to 60 micrograms before each meal. If it's type 2 diabetes mellitus, now this is much higher, 60 to 120 micrograms before each meal. Because in patients with type 1 diabetes mellitus, they are already requiring at least 3 injections per day, adding an amylin mimetic would add about another 3 medications to this. So imagine injecting yourself about at least 6 times a day, if not more. This would severely limit compliance. Another thing to consider is when we are prescribing amylin mimetic, we must make sure that the meal contains more than 30 grams of carbohydrates or more than 250 kilocalories. And therefore, if patients on a low-carb diet, perhaps this wouldn't be the most appropriate medication to prescribe. Now, if we think about the benefits of this medication, it leads to a modest reduction in the A1C, about 1%. There's also a modest weight loss of about half a kilogram, which is very important because, as we know, insulin leads to weight gain. It is unclear at the moment, but it appears that there's an improvement in the oxidative stress markers, which in itself are risks for cardiovascular disease. So it's hypothesized perhaps it is cardiovascular protective. Again, though there's not enough studies to safely say this. It appears that in patients with renal failure, it does not need a dose adjustment unless it's less than 15 milliliters per minute, which again is very important to note. Now, drawbacks to this medication. Like the GLP-1 receptor agonists, patients may experience severe GI discomfort, such as nausea, vomiting, anorexia. There are case reports of fatigue, headache, and dizziness, so we need to make patients aware of this. This medication has not been adequately studied in the pediatric population, so it should not be prescribed in this cohort. Again, as we've stated, we need to reduce the premeal or prandial insulin when prescribing pramlintide, and there's a great risk for hypoglycemia without the proper adjustment of insulin. Again, as this medication is slowing gastric emptying, there's a risk for delayed absorption of other medications, some of which may lead to increased absorption and perhaps an increased risk for hypoglycemia. It's also important to note that this medication should not be mixed in the same syringe as insulin. Some patients may think, oh, instead of taking 6 injections per day, I will just combine my insulin with the amylin mimetic. But no, this is not appropriate. Now, final cautions and contraindications. We really don't know the long-term outcomes of amylin. There's also not a lot of data on this because it's not commonly prescribed. We don't know, or not that we don't know, it's this drug can lead to hypoglycemia because you will be taking insulin concurrently. And in patients with hypoglycemia unawareness, it's perhaps best to avoid this medication. We also don't know the effects during pregnancy and lactation, whereas in insulin, we do know the effects. And a final consideration, like the GLP-1 receptor agonist class of medications, is to consider avoiding this medication in gastroparesis. Now let's look at another consideration of medications before we go on to the case studies. So as we can see on the slide, recently there's been an increase in the concept of combination medications. As you can see, there are multiple medications which have two different diabetic medications, and there's even a medication which has a diabetes medication and a statin. A statin is used to lower our LDL cholesterol. Now, there are benefits and drawbacks to this. The benefits being, of course, there's greater compliance instead of taking multiple pills. For example, if we look at Trijardi, they may only have to take one pill. As a result, when there are different medications together, there's some evidence perhaps there's less side effects. And again, when you have something such as Juvasync, which is sitagliptin, as well as simvastatin, you are tackling more than one pathology. In this case, it's decreasing the glucose levels and cholesterol all in one pill. The drawbacks, of course, combination pills are more expensive. If you need to adjust one of the various pills, you can't. Unfortunately, the dose changes affect all pills. And there's a greater risk for hypoglycemia, of course, when you're combining these pills and you can't adjust the individual dosages.
Now let us go on to the case studies.
Okay, so let's start with our first case study. A 45-year-old female with a long-standing history of type 2 diabetes mellitus is transferred to the emergency department by paramedics. On presentation, the patient is breathing laboriously and is complaining of nausea. Furthermore, a fruity odor is identified emanating from the patient's oral mucosa. According to her husband, the patient attended a follow-up appointment with their endocrinologist 4 weeks ago to commence a new diabetes medication. At the time, her glycated hemoglobin was 9.3%. Apart from recent vaginal thrush, the patient has not had any other complaints. After completing a physical examination and documenting in the patient's chart, the following laboratory results return. So as we can see, there's a BUN of 32, a random glucose of 198, bicarbonate of 12, pH of 7.3, urinalysis is positive for ketones, and slightly low sodium. The question is, which of the following class of medications was most likely commenced? Was it a biguanide, a sulfonylurea, a DPP-4 inhibitor, an SGLT2 inhibitor, or a GLP-1 receptor agonist? So we need to break this down first. If we start with, it's a patient with type 2 diabetes mellitus. She's presenting with deep breathing, so there's a fruity odor, and she was recently started on a new diabetes medication. She's also been complaining of vaginal thrush quite recently. So keep that in mind, and let's also look at the bloods. She's severely dehydrated, she has a high BUN, her bicarb is quite low, her pH is quite low, and she has a urinalysis positive for ketones. So it is important to note this is suggestive of diabetic ketoacidosis, but something that doesn't seem to fit with this criteria is the honestly quite normal glucose level in this presentation. So let's break this down into a few things. We know that to diagnose diabetic ketoacidosis, typically the glucose is more than 250. The bicarb is typically below 15, and the pH as well is around this level, if not lower. And of course, ketones would be positive as they are here. So what is going on here? The patient's also complaining of recent vaginal thrush, which seems to be after starting her new diabetes medication. So when we put this all together, what comes to mind is option D, an SGLT2 inhibitor. And the reason I say this is because this is a presentation of euglycemic diabetic ketoacidosis. As we discussed on the slide, an SGLT2 inhibitor may cause euglycemic diabetic ketoacidosis. So that means all the criteria of diabetic ketoacidosis are fulfilled except for the glucose level, because as how the medication works, it increases the urination of glucose, glycosuria, and therefore don't be fooled by the relatively normal glucose levels. The patient has fruity odor, she has deep breathing, and she appears a bit obtunded and is dehydrated, all consistent with a finding for diabetic ketoacidosis. Again, the vaginal thrush was a hint that she likely started an SGLT2 inhibitor because this is a very common complaint in patients on an SGLT2 inhibitor. Sometimes we tell patients to eat yogurt or something with probiotics in it just every night, and some patients swear it works, some do not. But regardless of that, it's important to note this patient was likely started on an SGLT2 inhibitor. Let us go to the next case study. A 62-year-old gentleman with a 22-year history of type 2 diabetes mellitus presents to his endocrinologist for a routine follow-up appointment. The patient is known for missing his appointments quite frequently, and he also admits to not always being compliant with his medications. His medications are Metformin, Linagliptin, which is a DPP-4 inhibitor, and long-acting insulin, this is Lantus, at bedtime. The physician decides to get a set of bloods, and we see the A1C is 8.1%. In someone like him, we would recommend either 7 or less than 7.5. If he's had diabetes for such a long time and it appears poorly controlled, a person would recommend that their A1C target should be 7.5%. We also see here the eGFR is 22 milliliters per minute, which is quite low. And as we know, the A1C can be affected by multiple things. We need to consider whether this could be affecting the A1C measurement. It is unlikely at this level. Perhaps if it was much lower, we would think that the A1C could be a false reading. Urinalysis was not performed. We see there's relatively normal sodium and potassium. So what should we do from here? The patient has a high A1C despite being treated with 3 medications. What is the best line of treatment? Do we reduce the metformin? Do we discontinue the metformin but continue everything else? Do we discontinue the linagliptin and continue everything else? Or do we stop the insulin and continue everything else? So it's important to remember that the eGFR here is less than 30, and therefore metformin is contraindicated less than 30. Remember, if it's between 30 to 44, we reduce the dosage. If it's above 45, we're not concerned. So definitely want to discontinue metformin. So anything that says continue it, let us cross out. As well, we're not reducing the dosage. We want to discontinue it outright. So why can we continue Lantus? I thought DPP-4 inhibitors must be stopped in renal failure, and that is true. All DPP-4 inhibitors except for linagliptin. Linagliptin is the one exception which goes to the hepatic recycling route and therefore can be continued. So we don't need to reduce or stop it. Now it's important to note that insulin is mostly metabolized by the liver. About 25% is metabolized by the kidney. And in renal failure, insulin levels can build up. We wouldn't stop insulin outright. We'd think about reducing the dosage, perhaps, as the insulin would last slightly longer in the system. But in this case, the best answer would be B, continuing linagliptin and Lantus, discontinuing metformin. And regarding this A1C, we wouldn't necessarily add a new medication. We'd make sure the patient is compliant with the medications already prescribed and then reassess in 3 months. Let's go on to another case study. A 26-year-old college student with type 2 diabetes mellitus and obesity has a BMI of 36, presents to his family physician. He is currently taking metformin and is also trying to increase his physical activity and improve his diet. Remember, we recommend a mixture of aerobic and resistance activity alongside a Mediterranean diet. The patient declines undergoing bariatric surgery and would like to know if any of the diabetes medications would help him lose weight. Which of the following classes of diabetes medications leads to weight loss? Is it a DPP-4 inhibitor? Is it a Meglitinide? Is it a Sulfonylurea? Is it a Thiazolidinedione? Or is it an SGLT2 inhibitor? So let's quickly remember that to undergo bariatric surgery, typically we say these are patients with a BMI above 40 or a BMI above 35 plus a comorbidity such as diabetes mellitus. Anyways, just a sidetrack, this patient doesn't want bariatric surgery anyways, so we ignore that. So which of these medications leads to weight loss? So let's recall these medications. A DPP-4 inhibitor, it increases the levels of GLP-1 and GIP by roughly 2 times. It's not super effective in that sense, and most patients don't lose weight. It's weight neutral. Definitely does not increase the weight, but it won't lead to weight loss. That's in contrast, of course, to a GLP-1 receptor agonist, which increases the levels multiple times and leads to weight loss. There's a Meglitinide and a Sulfonylurea as options B and C. Both of these act within the pancreatic beta cells to increase the release of insulin, and we know insulin leads to weight gain. Therefore, both of these options are incorrect. So between these last two options, a TZD or an SGLT2 inhibitor, a TZD increases the sensitivity of insulin within the periphery, and an unfortunate side effect is weight gain. SGLT2 inhibitors have multiple benefits. One of them is weight loss. So this would be our answer. So remember, the medications which cause weight gain are the meglitinides, sulfonylureas, TZDs, and insulin. SGLT2 inhibitors and GLP-1 receptor agonists lead to weight loss. Some people may find weight loss on metformin, but it's more commonly they would just be weight neutral. As well, DPP-4 inhibitors appear to be weight neutral. So let's go on to another case study. A 53-year-old female is diagnosed with type 2 diabetes mellitus after admission to the CCU, cardiac or coronary care unit, depending on where you live in the hospital and what it stands for a myocardial infarction. As we said, a lot of patients are diagnosed with type 2 diabetes on this ward after undergoing some sort of event, such as a heart attack. An endocrinologist referral is requested, whereby the patient is commenced upon 500 milligrams of metformin and advised to slowly titrate to 2 grams daily. She is subsequently discharged and advised to follow up with the endocrinologist in 1 month's time. Upon attending a follow-up appointment, the patient complains of severe diarrhea and refuses to continue her medication. What is the next best step in management? Should we stop the metformin and start her on long-acting insulin? Remember, basal is long-acting, nighttime insulin, bolus is also known as prandial or premial insulin. So we switch to extended-release metformin. Should we start semaglutide? Semaglutide is also known as Ozempic. It's a GLP-1 receptor agonist. Should we switch to ER metformin and commence semaglutide, which is option D, or should we stop metformin, start insulin, and start semaglutide, which is option E? So let's break this down. The patient has had a myocardial infarction. They've been diagnosed with diabetes. They've been started on metformin, but they are suffering from diarrhea as a result. As we discussed on the metformin slide in this talk, metformin is so important we don't want to stop it unless there's a contraindication. This isn't necessarily a contraindication, this is purely a side effect. And how do we manage the diarrhea? We switch them to extended release metformin. So definitely need to consider this as an option, but is this the only option? We discussed at the start of this lecture commencing basal insulin, and that would typically be when there's an A1C of more than 9 or 10%, when it's very, very high. It doesn't appear that is the case here. It's not stated, but also anyways, in option A, it says discontinue metformin, and we know that's incorrect. Now, this patient's had a myocardial infarction, and if we remember in the ADA algorithm, they broke it down into ASCVD, atherosclerotic coronary vascular disease, heart failure, or CKD. If someone is either at risk for or has had a myocardial infarction, they need to be on a GLP-1 receptor agonist as well with cardiac benefit. The ones with cardiac benefit, like the drug LSD, that's liraglutide, semaglutide, dulaglutide. Okay, so options B and C appear to be correct. And which one of these covers both? That is D, option B and C. Yeah, of course, if for whatever reason they could not take a GLP-1 receptor agonist, as we stated before, there are contraindications such as a family history of medullary thyroid cancer or multiple endocrine neoplasia, then we would start them on an SGLT2 inhibitor. So let us go to a next case study. As you can see, this is actually the same case as before, and it says she has subsequently switched to extended release metformin and advised to commence semaglutide. Semaglutide is also known as Ozempic and is a once weekly subcutaneous injection. So this question is asking in general, so forgetting the case study above, when you're starting a GLP-1 receptor agonist, which class of medications must be discontinued? So which one should not be prescribed concurrently with a GLP-1 receptor agonist? Is it basal insulin? Is it prandial or the mealtime insulin? Is it a DPP-4 inhibitor? Is it an alpha-glucosidase inhibitor? Or is it TZD? So as we know, there are medications that exist which combine a GLP-1 receptor agonist with basal insulin. Examples of this are Zoltofy or Celiqua. So that is incorrect. And we know that prandial insulin Many patients sometimes require GLP-1 receptor agonists and basal insulin, and even sometimes prandial insulin. We know there's no contraindication to that. We know that DPP-4 inhibitors act in a similar fashion to GLP-1 agonists in terms of increasing the incretin hormone levels in the gut. We know DPP-4 inhibitors only do a mild effect, and it doesn't appear that there is a benefit when the two are added together. There's actually just a heightened risk for GI side effects. So this is definitely an option that should be discontinued. We know most patients don't tolerate an alpha-glucosidase inhibitor from the flatulence, but there is no contraindication to combining it with a GLP-1 receptor agonist, and TZD increases the sensitivity to insulin in the periphery. There's no contraindication providing that combining that with a GLP-1 receptor agonist. If the question was which class of medication should be discontinued or the dosage should be reduced when commencing insulin, then it would be a TZD, because a TZD increases fluid retention, as does insulin, and there's a greater risk for heart failure or precipitation of underlying heart failure. But in this question, which medication class must be stopped when commencing a GLP-1 receptor agonist? That is simply the DPP-4 inhibitors, the dipeptidyl peptidase inhibitors. Now let's go into another case study. A 52-year-old female was diagnosed with type 2 diabetes mellitus 4 years ago after suffering a myocardial infarction. Unfortunately, she was lost to follow-up and did not take her metformin as prescribed. She decided to visit her family physician after noting increasing lower leg edema and shortness of breath, particularly at night. The astute family physician is concerned she may be in heart failure and requests an echocardiogram, which returns an ejection fraction of 41%. And as we know, this is low. This is concerning and suggestive of heart failure in light of her symptoms of leg swelling and shortness of breath. So it's important to know that diabetes is a major cause for heart failure. So in addition to recommending metformin, and again, it should be noted that metformin should be given with stable heart failure. So once she's been stabilized, which other class of medications should this patient be prescribed? Sulfonylurea, a DPP-4 inhibitor, a TZD, an SGLT2 inhibitor, or insulin. So if we recall from the ADA guidelines, there was the concern for ASCVD, we would give a GLP-1 receptor agonist. If there was concern for heart failure or chronic kidney disease, we would give an SGLT2 inhibitor. So that is our answer. And insulin and Thiazolidinediones, or TZDs, both increase fluid retention. While a TZD would be contraindicated in heart failure, insulin would be perhaps ill-advised if they didn't need it, if their A1C wasn't super too high, but it wouldn't be contraindicated. A DPP-4 inhibitor would not be helpful because it has no effect upon the heart, and certain medications actually, such as saxagliptin, increase the hospitalization for heart failure. Sulfonylurea, as we know, act similarly to insulin in the sense that they act on the beta pancreatic cells to release insulin, but would have no effect in heart failure. As we know, SGLT2 inhibitors are super effective in heart failure and are actually part of the recommendations even in patients without diabetes mellitus. And let's go on to another case study now. A 49-year-old accountant with a 12-year history of type 2 diabetes mellitus has recently been diagnosed with background retinopathy through a routine annual retinopathy screening appointment. So every year, patients with diabetes must be screened, undergo retinopathy screening and looked into their eyes so there's no complications. His endocrinologist makes requests an appointment and has the following laboratory measurements performed. If the A1C is 7.8%, for someone such as this patient, we'd recommend 7 to 7.5%. Kidney function appears to be slightly low, typically above 60 is what we would like. This one is lower than that. And they also note the UACR, which is the urine albumin creatinine ratio, is significantly elevated. Normal is less than 30. 30 to 300 is the microalbuminuria range, and more than 300 is macroalbuminuria. So there's high protein levels here in this UACR concerning for kidney disease, but we should never take one single measurement as proof for or against kidney disease. Multiple situations can lead to positive protein within the urine, such as if you have a fever, if you've recently exercised heavily, such as running a marathon. Certain medications can as well. If there's contamination, perhaps this is from the menstrual cycle, or perhaps there's a urinary tract infection. So we recommend taking measurements over 3 months, and at least 2 of the 3 being abnormal is confirmatory. So as we can see again, that's why this was repeated a month later, and the urinary albumin-creatinine ratio was quite similar at 210 milligrams per gram, and this is in the microalbuminuria range. So with this in mind, having protein within the urine, in addition to metformin, as we've emphasized over and over again, every patient should be given metformin unless there's a significant contraindication. So in addition to metformin, which of the following classes of diabetes medications is most appropriate to commence in this patient? Would it be insulin, an SGLT2 inhibitor, a DPP4 inhibitor, a meglitinide, or a TZD? So their A1C is not super high. It wouldn't be necessary to give insulin. It would increase the risk for a hypo, and as well as asking the patient to inject themselves perhaps once a day or more, something we shouldn't be asking patients to unless they absolutely need to. So there's no reason why insulin would be needed straight away. If we go down to an SGLT2 inhibitor, we remember in the ADA guidelines, do they have ASCVD, do they have CKD, or do they have heart failure? And this patient absolutely has evidence of CKD. They have an EGFR less than 60 with microalbuminuria. It's highly suggestive of chronic kidney disease, likely of diabetes or diabetic nephropathy. What furthermore suggests this is the fact that they have background retinopathy. As we know, there's 3 microvascular complications of diabetes to be aware of. There's neuropathy, damage to the nerves, retinopathy, damage to the retina, and nephropathy, damage to the kidneys. If there was a recent diagnosis, let's say 1 or 2 years, and they didn't have retinopathy, I wouldn't be so sure to say this decline in kidney function is due to diabetes. But since they have background retinopathy, they have a 12-year history of diabetes, it's quite suggestive that this is a result of the diabetes. So in that case, we know an SGLT2 inhibitor is very beneficial and is what's known as nephroprotective, will lead to a slowing and further decline of kidney function. We know, as we've said as well, that if an SGLT2 inhibitor is contraindicated, perhaps this patient has had recurrent episodes of ketoacidosis, we perhaps wouldn't give an SGLT2 inhibitor and would consider GLP-1 receptor agonists. So although they're not licensed for nephroprotection, the preliminary data is suggestive of GLP-1 receptor agonists having nephroprotective benefit. So DPP4 inhibitors, there's some evidence that they reduce proteinuria or albuminuria, but this hasn't conclusively been demonstrated to have any survival benefit, and it hasn't been assessed in the long term, and for the most part, it doesn't appear as if there's any a benefit in this prescription in CKD, so this would not be an appropriate answer. And meglitinides as well, we know they are like sulfonylureas, more recent developments, and they don't seem to have any effect upon albumin within the urine. It would be inappropriate. As well as TZDs, they don't have any effect upon the kidneys. They don't have any protective effect. While they may increase insulin in the periphery, the sensitivity of insulin, they don't have any effect on the kidneys and would be